Okay, 8 o'clock, we're going to start grand rounds. Thank you all for coming on this hopefully beautiful spring day. And we have our final chief resident presentation today, and to introduce Dr. Palmer. I am delighted to introduce Dr. Coyle.
Thanks, everybody. So like Dr. Schnapp said, really a bittersweet day. Today is our last Chief Resident Grand Rounds presentation, and I get to introduce Dr. Geralyn Palmer. So as you all know, Geralyn graduated medical school at the University of South Dakota Sanford School of Medicine before coming to do her residency here at UW. As a resident, Geralyn really distinguished herself as a wonderful clinician, an amazing teacher, winning multiple awards for clinical excellence and her humanistic approach to medicine. As a chief resident, Geralyn oversaw the creation of all of our intern schedules, a laborious but important task for which we are very grateful, and really has been a model for advocacy for resident education, equity and fairness in all that we do, and really a consummate teacher and educator. Throughout her residency, Geralyn has worked on a number of different scholarly projects related to transplantation, critical care medicine, and communication under the mentorship of multiple faculty, including Dr. Cruiser, who is here today, which is wonderful. Geralyn has been just an amazing member of our residency community for the last 4 years, someone who's made such an impact on the lives of all of our residents, and so grateful for all she's contributed to our residency community. Geralyn will be continuing her training as a pulmonary and critical care medicine fellow at Vanderbilt University in just a couple short weeks, and while we're sad to see her go, we'll know she'll do amazing things throughout her career. And so I'm really excited to hear Geralyn's talk today, focused on navigating uncertainty and supporting families in critical illness. Geralyn, I want you to take it away.
Thank you so much, Andy. Well, thank you so much for that warm introduction. Today, I will be discussing navigating uncertainty and supporting families in critical illness, a community perspective on time-limited trials. I have no conflicts of interest to disclose. So I want to start by talking about a patient's story. So this is a story of Ron. He is a Wisconsin native, 78-year-old man with hypertension, hyperlipidemia, heart failure, and in moderate dementia. He is on day 7 of his ICU stay, undergoing mechanical ventilation after he presented to the hospital with fever, altered mental status, and shortness of breath, found to have sepsis secondary to pneumonia. Unfortunately, Ron is still requiring high levels of oxygen support, and his medical team is uncertain of if or when the breathing tube can be removed. This is causing significant distress and uncertainty for his family. Ron's story is unfortunately not uncommon. As healthcare workers, we frequently witness similar scenarios in the ICU. In the United States, around 1 in 8 older adults spends time in an ICU near the end of life. Despite these care patterns, many older adults express a preference for end-of-life care that prioritizes comfort and symptom management over life prolongation. Importantly, when we fail to uphold these care preferences, we are compromising the dignity of our patients at the end of life. These experiences not only negatively impact our patients, but also their family members as well. Around 1/3 of surrogate decision makers experience persistent negative emotional burden after their loved one has left the ICU. Additionally, this also impacts healthcare providers, as providing care that may conflict with a patient's values or best interests can cause moral distress and lead to increased rates of burnout and depression. Knowing this, I think it's an important question to kind of wonder, how do we get to this ICU end-of-life care? Why do patients receive such invasive care near the end of their life? This question has been explored for decades, and there's no single answer that exists, but rather a complex interplay of factors that are shaping these care patterns that we observe, including family dynamics, patient values, and the clinician perspective. There's rarely one clear factor driving ICU admissions near the end of life. And I also think it's important to note that many times when a patient is being admitted to the ICU, they are not aware that this might be their end-of-life care. Recognizing this, if we return to Ron's story, I think we can ask ourselves, how can we improve as a healthcare system this ICU end-of-life care? Through this talk today, I hope that you will be able to perform these various objectives that we'll go through throughout my discussion. Today's outline, we'll talk about advanced care planning. We'll talk about the surrogate experience, making medical decisions for loved ones in the ICU, and then an introduction to time-limited trials. So first, in discussing advanced care planning, through this section, I hope that you'll be able to describe the components, evolution, and current definition of advanced care planning. I hope that you'll be able to summarize the role and limitations of advanced care planning in ICU end-of-life care. And so to explore this, we can ask in the context of Ron's story, does advanced care planning help reduce unwanted end-of-life care? To answer this, I think it's helpful to understand the history of advanced care planning. This was initially introduced in the 1960s and 1970s, along with the advancement of medical technologies like mechanical ventilation and dialysis, so that patients could maintain autonomy if they weren't able to express their care preferences themselves. A lot of the time, this was in the form of documentation, such as advance directives, living wills, power of attorney forms. And then in 1990, Congress introduced the Patient Self-Determination Act, which required healthcare providers participating in Medicare and Medicaid to inform patients of their rights and to document any advance directives they may have. Through this evolution, healthcare providers and researchers began to recognize that documentation alone may fall short in guiding patient care due to limited scope and accessibility. This expanded the definition of advanced care planning to include ongoing conversations about patients' values, goals, and preferences. With this evolution of advanced care planning, we saw an uptake in various forms of this. This is an article from NPR, actually about Gunderson Health in La Crosse. In the 1990s, a physician, Dr. Bernard Budd Hams, who is an ethicist, implemented something called Respecting Choices in La Crosse, where he trained healthcare providers on advanced care planning conversations and emphasized person-centered decision-making. With this intervention, in this 2014 article, they recognized that for individuals that passed away in La Crosse, around 95% of them had an advance directive on file. This is a pretty significant uptake compared to what we see more globally in terms of advanced care planning, where around 20 to 50% of individuals over the age of 50 have some type of like advanced directive or engagement in advanced care planning nationwide. With this growth and evolution of advanced care planning, a group of advanced care planning experts met in 2017 to come up with a consensus definition because it became challenging when studying the role of advanced care planning due to various definitions. And so this group describes advanced care planning as a process that supports adults at any age or stage of health in understanding and sharing personal values, life goals, and preferences regarding future medical care. Again, this definition emphasizes that, that this is an ongoing conversation at any stage of health. The goal is to create a clear, concise, and universally applicable framework for healthcare professionals and establish a foundational standard to guide ICU research and inform policy. With the evolution of advanced care planning, there's also been numerous promises to patients, families, and clinicians about what this can do for us in the setting of critical illness. This is adapted from a systemic review on advanced care planning that was looking at specific outcomes or interventions related to this. Some things that have been studied or tried to attribute to advanced care planning include increasing do not resuscitate orders, improving quality of life, decreasing hospitalizations, promoting goal concordant care, amongst many others, as you see listed here. Unfortunately, because of this, I think there are many competing expectations, and it raises the question, are we asking too much of one single intervention? It is possible that we are looking at advanced care planning as a cure-all, which, particularly in the context of end-of-life care in the ICU, the complexities of prognostication, family dynamics, and medical uncertainty may go far beyond what advanced care planning alone can address. I think more globally speaking, we could ask, does advanced care planning impact patient care? to answer this question, I looked at two different systematic reviews. One was published in 2018, and it was a systematic review of systematic reviews and included over 1,600 original articles. There was another systematic review done in 2021 that was of randomized control trials and included 60 high-quality control trials in this analysis. In both of these systematic reviews, they found improvement in advanced directive completion and end-of-life care planning with various advanced care planning interventions. This would include things like increasing conversations, having like written tools or interventions to facilitate that as well. While I recognize this is not directly involving patient care, I think it's important to understand that they do increase conversations regarding advanced care planning. However, when we start to look at does this impact patient care, that's where I think things start to get a little bit more controversial. In the 2018 systematic review, there were mixed results in terms of out-of-hospital death. Again, this would have been like the patient's preference for out-of-hospital death and whether or not that actually occurred. There was mixed results in regards to quality of life or improvement of that, and then end-of-life care. In the 2021 systematic review, they found mixed results in regards to hospital transfers. The one situation they found somewhat beneficial is if a patient is in a nursing home with an advanced directive, but otherwise there was no significant benefit for out-of-hospital death and minimal to no benefit in quality of life or goal concordant care. In the randomized control trials studied here, I think it was 0 out of 11 produced goal concordant care with advanced care planning. So, recognizing this, are we asking too much of advanced care planning to predict and guide future treatments? Medical literature has called attention to advanced care planning limitations, particularly in the last 5 to 6 years, in reliably upholding patient preferences and informing real-time clinical decision-making. These are just some of the various articles that have kind of explored this and questioned whether advanced care planning is appropriate, particularly in impacting ICU end-of-life care. Some of the limitations of advanced care planning that have been discussed in those articles and in previous studies is advanced directives versus advanced care planning. There are some studies that show that completion of advanced directives may unintentionally limit further conversations between patients, families, and clinicians. And so rather than using their advanced directive as a starting point, they view it as a definitive plan to prevent ongoing conversation. Additionally, advanced directive documentation is very variable. There's no standard amongst states, amongst cities, amongst healthcare systems. And then it's also difficult to find access to it when we need it in clinical moments. They may also not contain information relevant to the specific clinical situation that we are asking. Additionally, it's important to recognize that patients are complex and evolving. This is influenced by their age, physical or cognitive function, and various family perspectives. And so again, it emphasizes the importance of longitudinal conversations, but even in the moment, things may change for patients and their families. There's also limitations in regards to the surrogate experience. They have significant emotional weight, making medical decisions for their loved ones in critical illness. There are challenges for surrogates to be able to extrapolate knowledge from previous conversations and take that and apply it to clinical situations, particularly because there is so much nuance in caring for patients in the ICU. Lastly, when thinking about planning versus reality, I think we can have an idealized conversation about what end-of-life care looks like for patients when we're in the clinic, in the office, or if they're talking around the dinner table. But perspectives may shift significantly in the face of serious illness, and we cannot fully anticipate how patients or families will feel or what decisions they will make when actually facing a life-threatening situation. All of these reasons underscore a key point. While advanced care planning can help clarify values and preferences, it has limitations when applied to real-time, high-stakes medical decisions, particularly in the form of an advanced directive. Some have argued that rather than relying solely on documents completed in the past, we should prioritize supporting patients and families in the moment, making values-based decisions where they're grounded in the patient's current goals and clinical context. With this in mind, we may consider shifting our focus from relying on advanced care planning to influence ICU end-of-life care as a measure of goal concordant care, and then to understand the influence of in-the-moment care preferences. This helps us acknowledge the patient's current medical condition and evolving goals, which leads to more relevant and meaningful patient care preferences. To explore this further, I was able to work in Dr. Cruiser's lab with Cara Donovan on a project analyzing the goal concordant care in patients receiving mechanical ventilation in the ICU. This project was a single center study at an adult medical ICU for patients receiving mechanical ventilation. At enrollment, surrogate decision makers were asked if they had ever had a conversation with a patient regarding their care preferences at this point in time. If they had had a conversation, they were asked to select from 3 different options of what they believe would reflect the patient's goals and critical illness. If they had not had a previous conversation, we asked, based on what you know, which of these do you think best describes their overall goals for medical care at this point in time? The 3 options to choose from were to live longest or live as long as possible, even if that means uncomfortable medical procedures or treatments, to choose some limitations or try to live as long as possible, but I may decide that some uncomfortable procedures, treatments, or long-term life support are unacceptable to me, or to maximize comfort, meaning to maximize my comfort and quality of life, even if that means my life is shorter. With these responses, we were able to get around 217 surrogate responses that identified patient care preferences in the ICU. We then took this data and organized it by these groups or care preferences. And then we looked at various treatments or the care that was delivered to patients between these groups. From this, we found that patients whose surrogates identified that they would prefer maximized comfort had a shorter hospital length of stay compared to those that would with goals to live as long as possible. Despite this, we found that there was no difference between groups in terms of ICU length of stay. There was no difference in total length of mechanical ventilation and no difference in rates of tracheostomy or rates of ECMO. Again, I think this highlights that in these specific clinical scenarios, despite having goals of care that might be consistent with maximizing comfort, it's unclear if those patients are receiving that in the ICU. This is also reflected in looking at their hospital outcomes, again, by surrogate reported goals of care. And so between these 3 groups, we did not find any difference in regard to mortality or patient disposition at discharge, whether it's to a facility. There was no difference between groups on patients that were discharged on mechanical ventilation, no difference in patients that were discharged on hemodialysis or discharged with nutritional life support. Again, reflecting that despite having preferences for maximized comfort, they're receiving similar treatment to those with a preference to live as long as possible. To summarize these findings, we could say that surrogate reported goals of care reduced hospital length of stay, but they did not have a significant influence on the care delivered in the ICU. So specifically looking at ICU length of stay, rates of tracheostomy, duration of mechanical ventilation. This suggests that even when surrogates express a preference for comfort-focused care, the clinical care provided may not fully reflect those wishes. This highlights that there is a gap even within the moment patient preferences in clinical practice. To summarize advanced care planning and goals of care in critical illness, advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. Again, I want to emphasize that this is a longitudinal conversation, not just a one-time filling out of a document. And advanced care planning can have a positive impact on creating conversation, making patients or families feel empowered, and having documentation of care preferences. However, there's an uncertain or unclear influence of this on patient care, particularly in the ICU. This brings up, should we shift our focus to understanding and exploring in the moment conversations, decision-making, and approaches to patient care? We recognize that in the study I worked on with Cara, there was no significant difference in care patterns or despite the indications on goals of care or care preferences, which brings up, are there other things going on with ICU level care that is impacting the care patients receive? If we were to go back to Ron's story and kind of ask ourselves, how did we get to day 7 of mechanical ventilation in the ICU? We could go back to the start of his hospital stay when Ron presented to the emergency department with shortness of breath, fever, and altered mental status. On Ron's chart, they were able to see that he has a preference for do not resuscitate, but that this is significantly outdated, and there was no indication for if Ron would want mechanical ventilation. They also looked and found that he does have an advanced directive on file. This is one of the living wills that the state of Wisconsin has on their websites. As you can see, Ron does not want a feeding tube, and unfortunately, that is kind of all that is reflected in these documents. And so they then found that Ron had a power of attorney for healthcare for him in his chart as well. This identified his son Paul as his healthcare agent. And again, on this form, we found that Ron does not want to go to a nursing home or a community-based residential facility. And again, that he does not want a feeding tube. But unfortunately, this is all that's indicated in the power of attorney for healthcare form as well. Knowing this, the ED providers called Ron's son Paul, and they could tell that he sounded overwhelmed on the phone when being asked what they should do for his dad. He remembers he had talked to his dad about these types of things, but it was years ago, and he's not entirely sure what his dad would want at this time. He remembers that his dad said, well, you could try, but I don't want to be on machines forever. So he says, oh, okay, to proceeding with intubation. This is how Ron got to day 7 of his hospital stay, despite having advanced directives and prior conversations for advanced care planning. As you can see, there were significant challenges. Although conversations had been held, it was a year prior to his current presentation, and there were different family, patients, and medical factors that had evolved. There is also significant stress in making these decisions over the phone for patients and loved ones. And so that brings us back to the question, how can we improve ICU end-of-life care if there is no significant impact or influence from advanced care planning or other efforts outside of this setting? I want to next talk about the experience of surrogates making decisions in the intensive care unit, because I think this can largely impact the experience of patients and families. In this section, you will be able to identify the challenges of surrogate decision-making in ICU end-of-life care and define decisional conflict, its key components, and its role in surrogate decision-making. So as briefly touched on before, nearly half of all surrogate decision makers experience negative emotional burden when making medical decisions for a loved one. Key stressors include uncertainty about the patient's care preferences, unclear prognosis, and the heavy responsibility of making medical decisions in the face of uncertainty. This emotional strain can impair the surrogate's understanding of the clinical situation, delay decision-making, and can contribute to anxiety, depression, and PTSD even after their loved one has left the ICU. One specific emotion that we can study in surrogates while making decisions in the ICU is something called decisional conflict. This is a state of uncertainty related to a course of action. It can lead to delayed decision-making and increased emotional distress amongst surrogate decision makers. And studies have shown that ICU surrogates experience high levels of decisional conflict, but little is known about how or why this experience may vary amongst individuals. Therefore, I was able to work on a project, again, with Dr. Cruiser, asking the question, are there surrogate or family-specific factors we can address to improve decision-making and reduce decisional conflict? The study I was able to take part in was a 12-month single-center survey study here at the University of Wisconsin. Surrogates of patients with acute respiratory failure receiving mechanical ventilation for over 48 hours were identified and sent the survey on decisional conflict. Decisional conflict is a previously validated scale, and there's 5 different domains to this, including how well a surrogate feels informed, if they feel clear about their values, they feel supported in the decision that they're making, if they have any sense of uncertainty, and then if they feel that they are making an effective decision. When responding to this scale, surrogates respond by Likert, and then these scores are transformed, and a score of 0 is like little decisional conflict, and a score of 100 would be the highest level of decisional conflict. We had 76 individuals or surrogates respond to this survey, and then we took this data and their decisional conflict scores and separated them into quartiles based on their overall score. I included this graphic because I think it's interesting to note the large distribution of decisional conflict that surrogates experience while they are in the ICU. The black line is delineating where we would define lower decisional conflict, and then between the black and the gray line, we consider moderate decisional conflict. So in particular, the patients or the surrogates that are experiencing high decisional conflict, there's quite a large variation in thinking about like what factors are driving that. We took the quartiles and then we tried to identify if there were any surrogate or patient factors associated with higher decisional conflict. This ties into our most recent conversation about advanced directives and advanced care planning. So specifically, we found that the presence of an advanced directive had no significant impact on the quartile of surrogate decisional conflict. And similarly, if they reported prior discussion with patients about their care preferences, this again had no influence on the quartile of their decisional conflict. Then we tried to identify if there were surrogate characteristics or specific factors that were associated with increased decisional conflict. Interestingly, we found that individuals that had higher levels of education had higher decisional conflict. And then we also found that surrogates with prior experience making medical decisions for another had lower decisional conflict. And we asked surrogates, how certain are you that your indication or that these decisions were what the patient would want? And if they were really uncertain, this was associated with higher decisional conflict. So from this study, I think it highlights several important points about surrogate decision-making and decisional conflict in the ICU. First, we observed marked variation in decisional conflict, recognizing that there are diverse experiences in surrogate decision-making in the ICU, and that it may be beneficial to identify those at high risk for high decisional conflict. Additionally, we found that there was no association between traditional components of advanced care planning and surrogate decisional conflict. This has been previously observed in other studies as well. And we recognize that prior experience with medical decision-making appears protective. Unfortunately, it's hard for us to simulate these types of experiences for surrogate decision makers before they come to the ICU to try and reduce decisional conflict. And so I think it is clear that we may need to identify other strategies to help support surrogate decision makers in this setting. If we were to go back to Ron's story and think about the significant emotional burden that a surrogate decision maker experiences in the ICU, we could understand that Ron's son, Paul, may be experiencing significant distress, particularly if he has never had an experience like this before. And so again, how can we improve ICU end-of-life care? This is where I want to introduce a new approach to patient care known as time-limited trials. In this section, we'll define a time-limited trial in critical illness and then examine the role of a time-limited trial in ICU end-of-life care. So time-limited trials, they're an established approach to patient care. We saw this first in critical care literature in around 1998, but it's been used in other fields like neurology, nephrology, palliative care, and surgery as a way to address uncertainty while keeping in mind the patient's overarching goals and care preferences. In recent years, we have seen a significant growing interest in applying time-limited trials to the field of critical care. This is a PubMed search for time-limited trials, and as you can see, there was a significant increase in publications in the last 10 to 15 years. Part of this is thinking that time-limited trials may align with the preferences of older adults who seek to balance potentially beneficial treatments and avoid prolonged unwanted intervention. Individuals believe that time-limited trials can address prognostic uncertainty and guide decision-making in real time. In 2024, at the American Thoracic Society meeting, a group of critical care physicians came together to develop a consensus definition of a time-limited trial as it relates to critical care. This focus group defined a time-limited trial as a collaborative plan amongst clinicians and patients and/or their surrogate decision maker to pursue life-sustaining therapy for a defined duration, after which they would reassess the patient's clinical course. I want to emphasize that one unique aspect of a time-limited trial is that this is a collaborative plan, meaning that we want to understand the patient's preferences and make a shared decision with the patients and the patient's families. After this period or this response to therapy, it informs the decision to either continue care directed towards recovery, transition to care focused exclusively on comfort, or extend the trial's duration. In clinical practice, some observational studies have found that 10 to 30% of patients in the ICU receive some type of time-limited trial. Despite this, there is limited literature on the impact of time-limited trials on patient care in a prospective manner. There is one study that was done in California at 3 academic institutions and they focused on training healthcare providers on how to communicate about time-limited trials with patients and their families. In this study, they measured patient outcomes prior to this educational intervention, and then they again measured outcomes such as hospital length of stay, ICU length of stay, et cetera, after this educational outcome. What they found is that there was a significant decrease in ICU length of stay after the implementation and training of how to approach conversations related to time-limited trials. While hospital mortality remains unchanged, again, their hospital stay was reduced and they frequently underwent less invasive interventions. Despite this promising data, little is known about patient and family caregiver perspectives on time-limited trials as an approach to patient care. Recognizing this and knowing that time-limited trials are becoming increasingly popular within the field of critical care medicine, I was able to work on a project in Dr. Cruiser's lab known as the Wisconsin Partnership Program. This is a project that was conducted in partnership with the Wisconsin Area Health Education Center. And we work with community organizations across the state of Wisconsin to engage community members and to better understand their perspectives on time-limited trials. I've included photos of Sean Mortensen and Joy Moy as they have been integral to this study. Again, this study was focused on holding interviews and focus group with community members to understand their perspective on time-limited trials as an approach to patient care. To recruit participants for this study, we purposely sampled to include individuals with different racial, ethnic, and geographic backgrounds. And we included adults over 65 years with greater than 1 medical condition, or adults over 18 years with experience making medical decisions for a family member. Again, we held individual focus groups or individual interviews in focus groups with these individuals. And this was held across different parts of Wisconsin, again, to try and have a diverse range of perspectives based off of patients' demographic data, but also lived experiences. So we've been to Winnebago, Manitowoc, Dane County, and Milwaukee, holding focus groups there in partnership with various community organizations. In the interviews, we had 2 separate longitudinal interviews, And in the first one, the participants were provided a written case about a patient who presented to the ICU with critical illness and underwent a time-limited trial. At the end of their trial, it resulted in recovering in the hospital and then going to a rehab facility and then home. And the next set of interviews, they were provided a case or scenario where the same patient underwent a time-limited trial and then unfortunately passed away. With both of these situations, we asked participants to reflect on their overall impressions of time-limited trials as an approach to patient care, and then give us input on specific components and implementation strategies. Through the process of design thinking, insights from these discussions inform the development of a decision aid or tool designed to support conversations between clinicians and families when considering a time-limited trial. This is the care plan that we have come up with to facilitate discussion with families on implementing time-limited trials and include important things related to the definition, including today's date, trying intensive care for an undetermined duration. And again, this is made in shared decision-making with the patient and their family. This is left open-ended so that clinicians can feel empowered to choose it in like hours to days to weeks, depending on their clinical presentation. And then they select a date where they will reassess. Within this time frame, we also encourage patients or families to look for different things for signs of like improvement or worsening. And then at the bottom of this tool, we ask, what would blank say about this? And this is where we put the patient's name and make sure that their preferences and wishes are kind of reflected throughout the care plan in this tool specifically. Using this tool, we also made a video that simulates conversation with a healthcare team and then a patient's family. And in this, they're discussing a plan of care using a time-limited trial. Using this video, along with the clinical scenarios and interview prompts, we gathered feedback from community members to understand how to best support patients and families during time-limited trials. Some of the initial feedback we received was endorsement of time-limited trials. One individual said, "Can everybody get this? This is a good plan. I don't think it's like this enough. It gives people more control without losing hope. It seems like there's only two choices most of the time. Fight till you know you're a vegetable or stop fighting right away. And this gives you that extra step of, taking everything into account." This highlights that time-limited trials allow patients and family members to feel empowered while navigating uncertainty of critical illness, allowing for time to assess if goal concordant care is possible. Another endorsement of time-limited trials from a surrogate in a focus group was, "I love this. It removes the feeling that everything is both critically emergent and could be indefinite. The incremental piece feels very contained and safe. I think that's very helpful. You're giving people permission not to have to think beyond those 4 days." Again, this quote highlights that time-limited trials make critical illness and decision-making feel more digestible for patients and their families. We then asked about specific components of time-limited trials to understand their perspectives. In relation to time frame, one participant said, "I think saying a time, whether it's 2 days, 4 days, or just saying a time, then you know what's coming." Another participant commented, "One thing just came into my head here. They said, we'll reevaluate in 4 days, but maybe they should have said, or sooner if needed, so that you know if he changes, they're available to talk to you." These reflections underscore the use of a time frame may help reduce inherent uncertainty of critical illness by giving some form of what surrogates or patients or families can expect during their ICU stay. It may reduce the stress of a surrogate decision maker by not having to look beyond those 4 days when making a medical decision as well. We also asked about the use of milestones within a time-limited trial, with one surrogate reporting, "Because the family wasn't even prepared for the possibility that he would make it, so that's a huge task, and that's probably all they could absorb. But here's what we're going to look for, and this is what we're going to do in the case of him worsening, improving, or worsening." In this quote, I believe it helps us understand that milestones can help families navigate uncertainty by setting expectations. Additionally, allows them time and then also empowers them to observe how a patient is doing clinically and allows them to prepare for that time of reassessment based off of what they've been seeing within that time frame. In regards to reassessment, one surrogate or older adult said, I think that's a great to follow up. We need to get back and talk. I want to sit down and talk with you as you're the doctor. I want to know what's happening. Has he improved or worsened? Because I already at home already talked to the family and we're going to do this. We're preparing for this if he did not improve. This emphasizes that families value clear follow-up to guide decisions and align plans based off of patient preferences. Again, this time frame can also give families a crucial window to an emotionally and practically prepare for different potential outcomes. Lastly, time-limited trials help to navigate the uncertainty of critical illness. One participant said, well, you know, within that certain length of time, you'll get some kind of answer, or maybe before that, there will be improvement or something, or go downhill. So that would help to prepare. Again, this reduces prognostic uncertainty by allowing for families time to observe a patient's clinical trajectory and to prepare for potential outcomes. With all of these thoughts, one thing that was pervasive and something that we noticed in almost every interview or focus group was the value of high quality communication between healthcare providers and patients and their families. There are various aspects to high quality communication that were identified, including individualization or making sure that we understand the patient as a person and their preferences moving forward. That healthcare providers are transparent and honest if they are worried about death as a potential outcome, and that they are consistent in their conversations, whether that's daily updates, but then amongst different members of the team as well. Participants also emphasize the importance of language and then cultural humility and making sure we understand the backgrounds of our patients and their families. When we have high quality communication, that helps to facilitate and implement time-limited trials. In summary, the perspectives we've learned so far by engaging members of the community is that they believe time-limited trials help to address uncertainty in patient care by creating bite-sized ways to process information and to address uncertainty without being subject to clinical momentum, or the idea that once an intervention starts, everything kind of adds up throughout a patient's hospital stay. It also supports shared decision-making and emphasizes time and reassessment so that families can observe what is happening and time to reflect and adjust the plan. Again, it also centers communication. It demonstrates that the time-limited trials may only work with high-quality communication that is honest, consistent, and compassionate. Some of the future directions for this study include completing an analysis of the focus groups to fully understand and integrate community perspectives onto the implementation of time-limited trials. We also hope to pilot and refine the communication tools to support implementation of time-limited trials in the ICU setting, and to evaluate the impact of time-limited trials on patient and family-centered outcomes in critical care. If we were to take time-limited trials and go back to Ron's story, we could imagine that after Ron was initially intubated and in the ICU, that his healthcare team met with his family and developed a plan of care with this time-limited trial tool. They identified today's date as May 31st, and that they agreed to try intensive care such as antibiotics, fluids, pressors, and mechanical ventilation for 3 days. During those 3 days, the medical team talked about ways that the family can look for how Ron is doing, if it looks like he is improving, or if there is concern that he may be worsening. And then throughout all of this, making sure that we understand what is important to Ron throughout his stay or his critical illness. So what is most important to Ron? Potentially spending time with family, and he would not be okay with long-term machines. Again, we can help identify when the medical team can meet and rediscuss and assess how Ron is doing before deciding whether to pursue care directed toward recovery, pursue comfort-focused care, or try another time-limited trial. I hope in today's talk, we were able to talk about that many older adults receive invasive end-of-life care despite preferences focused on comfort. We were able to understand that advanced care planning fosters meaningful conversation and patient autonomy, but has limited influence on ICU care and patient outcomes. And that surrogate decision-making in critical illness is emotionally complex, often marked by uncertainty and decisional conflict, even when advanced care planning is present. We can also recognize time-limited trials that offer a structured, collaborative approach to align care with patient values during uncertainty of critical illness. And I hope that moving forward, we can have continued incorporation of community perspectives and refinement of our communication tools and further evaluation of time-limited trials to help us understand if this is an effective way to care for older adults in the ICU. I would like to thank a significant number of people who have supported me throughout my process in residency. Dr. Cruiser has been an amazing mentor for me within my pursuit of research, and there are lots of wonderful people within Dr. Cruiser's lab that have pushed me to ask critical questions and think creatively. We also have a significant number of collaborators on our WPP project on time-limited trials. And then I would also like to thank Andy for giving me the opportunity to pursue this past year as chief resident and being an exceptional mentor and educator. Dr. Smith was my APD throughout residency and offered great support. And Dr. Brian Griffith, Dr. Runo, Dr. Sodi, and Dr. McCartney have all been outstanding clinical mentors. I'd also like to thank my co-chiefs, Mazen, Lucas, and Haley, who have endured and laughed with me this past year. I couldn't have done this without you guys, and I will always remember the emails we sent. But our chief dinners at Petra and everything in between. I would also like to say thank you to my Madison family. This is my Aunt Francine. She's 96, and I spend time with her as often as I can. They've been incredible support for me throughout my residency experience. And then I'd also like to thank my own family. This is us on vacation in Florida, and just even having support from them from afar has been incredible while I finished my training here at Wisconsin. So thank you all so much, and here's the link.
All right. Thank you, Geralyn, for a wonderful talk. And I think a really wonderful overview of your work, your research, the field, but I think also a great call to action for all of us to make sure that we deliver care that is truly patient-centered and aligned with their goals. What questions do people have for Dr. Palmer? I'm always looking at you, Dr. Schnapp. You get the first question, so.
Thank you, Geralyn. Great talk. Really interesting topic, close to my heart. I'm very curious about the study on surrogate decision-making conflict. And you listed several parameters that did and did not correlate. I'm wondering, have you looked at additional factors such as, faith or decision makers who live in the same city or frequency of interaction with patient, et cetera, that might influence?
Yeah, that's a good question. I think in our study, we did look at like other factors like gender. I don't think we had access to religious information in our review, but those would all be really great things to kind of look at. I'm trying to remember if other studies had, but some of that's more like data that's a little bit harder to collect. We weren't able to glean as easily from the chart. We did look at like ethics and palliative care consultations and those types of things. But yeah, understanding like the perspective of patients and surrogates is important.
And then in terms of the time-limited studies, which I fully endorse, I feel like we, as a critical care doc, we often have in our minds that we're doing a time-limited trial, but fail to articulate that to the family. So can you comment how we should be communicating that to family?
Yeah. Yeah, that's a good question. I think what might be helpful is being able to use like a tool similar to what I showed in the presentation, because I think that that facilitates conversation and then becomes more clear to the family as well that we are attempting an approach for time limited trials. It also allows the family to kind of like take that piece of paper home and understand like this is the plan, and that if another physician comes on, that they have like something definitive on paper that they can reference as well to kind of continue that time limited trial for the patient's hospital stay.
We have a bunch of questions online, so I'll go to one of those. So Dr. Griffith just got a shout out, also answering our questions. Had an excellent talk, Dr. Palmer. So I had a question that saying that the surrogate narratives are quite compelling while advocating for the benefit of time-limited trials. Do you think the benefit of time-limited trials would expand further if physicians working in the space of critical care, had access to more data and were better trained about prognostic factors and things that impact the direction their patient's care might go?
Yeah, I think that's one of the things that's kind of a something that's been brought up as a potential limitation, is just understanding that there is like prognostic uncertainty in critical illness. But I think that time limited trials actually help to kind of address that by giving you a defined period of time where you can kind of watch if a patient is improving or kind of staying the same. I hope that as research continues within this space, that providers will become more aware and likely more comfortable with talking about time-limited trials with patients and their families, which would help with implementation as well. And hopefully being able to use it again as a tool to navigate uncertainty, kind of understanding that there's prognostic uncertainty in critical illness, but I don't know if that will go away necessarily.
I think a follow-up to that was, should the concept of time-limited trials be added to the medical school and we'll say residency as well curriculum? Should be something we more formally teach to trainees early in their process as they think about navigating the complexities of critical care.
Yeah, I think, I mean, I believe in time limited trials, but I think I kind of touched on there's not a lot of like prospective studies to really back up. There are some convincing arguments for it, but I think just to make sure that we're introducing something that aligns with patient and surrogate goals and that appears effective is important. So maybe in the next few years, we can include it in curriculum.
A wonderful talk. As a primary care doctor, I think a lot about the abstractness of trying to describe what might happen in the ICU. And I think this is a very nice approach. And I'm thinking about in Ron's story.
Yeah.
So the thing that's going to improve is mental status. And if mental status doesn't improve, then perhaps it's time to stop,
Yeah.
And so I think families get extreme hope that, Ron, responding in some way is mental status is improving. And the family doesn't know what better ventilation status means. So
Yeah.
I'm wondering how that works, because I think that abstract part is very difficult for people with lots of hope to take objectively.
Yeah, that's a good question. And I definitely understand. We see that even now, just in talking with patients in the ICU or their family members. I think one thing that has been brought up a lot in our focus groups is community members were talking about making sure that in this like conversation and plan that you're creating something that like surrogates can understand. And so I just tried to be kind of like vague in what I was writing down, but some people were like, I want like a more detailed explanation if they have some type of like healthcare background. Or some people are like, I don't even understand what it means to look for things. So this would be overwhelming to me. And so again, I think that's kind of going back to like making an individualized plan depending on where patients and surrogates are. And then I think too, like if they have questions, there's like nursing staff always available. People in our focus groups emphasize that that is like invaluable for their prior experiences. And so having somebody that can help them like interpret what that means, because we have heard some concern about like, oh, if you go from like 60% FiO2 to 55, that they're going to be like, oh, they're significantly improving. And so again, I think that helps to have like clinicians there to interpret what that means in a clinical context.
Thanks for the great talk, Geralyn. One thing that I often think about, like as a resident, when rounding on large teams, is consistency and communication. And I know that that was brought up as one of the important factors. And I was just wondering that, like if you came across any strategies to ensure consistency of communication with these patients, especially, working in large multidisciplinary teams.
Yeah, in terms of, like, you're saying like between other like specialties and stuff, or just like day-to-day updates? Both, maybe? Okay, yeah. So I will say, like, the one study that I showed that was like a prospective study on time-limited trials, they actually looked at like different measures of high-quality communication, and they found that having like the training and implementation of time-limited trials improved communication. There are like various measures that they were looking at. They had like recorded those conversations. And so I think having a plan that kind of like facilitates communication is helpful. And I think maybe thinking about like the different specialists, it might be beneficial if they're present when you're making the plan. Yeah, I think a lot of times the onus is kind of on the primary team to make sure that we're all on the same page. And I haven't run across, I'm sure there's like literature on how to like facilitate that to make sure that you have like a clear and consistent message. So really good question. I think there's some promise in regards to time limited trials, creating more consistent communication, but um, among specialties, I'm less sure. I'm sure there's ways we could address it.
Thank you, Geralyn, for a wonderful talk. My question was relatively similar to Kendra's. I was just wondering when there is significant conflict between teams. I know obviously trying to get everyone on the same page, but when families are hearing maybe different messages from different specialties, especially patients who are so critically ill and so complex, and there's, like all these different teams involved. If teams are not able to get onto the same page, do you have any like thoughts or recommendations or next steps on how to address that when they have different ideas of what a time limited trial should mean for those patients?
Yeah, that's a good question. I think, and this is maybe me talking more off of my personal experience and less in terms of like what I've read. I'm not as familiar with the literature behind it, but I think trying to like meet as providers outside of like the patient and their family to try and come with some like consensus of like understanding the patient's clinical care. I think like having discussion can be really helpful. But again, not in front of like the patients or like surrogates, because I think that can lead to confusion. In regard to if people do not disagree at all, I'm not entirely sure like how that would look in terms of like a time limited trial. If it's something that like a medical team could express to like a primary clinician, again, not in front of the family. It's a good question. I'm not sure if there's like a lot of literature on it, at least in this context.
I guess in sort of time limited trials, did you see, predictive tools, Apache otherwise, are those used frequently in these as outcomes, or they tend to be more sort of patient-centered ones as you described here?
Um, I think it's been more patient centered. I'm not sure if I've like read in terms of like, I'm sure there's some studies. No, there's not.
Perfect.
Thank you.
Makes sense. Are there other questions from the in-person audience? So I gotta walk over here too. Oh, great. Sorry, Marissa, Michael's closer and I'm lazy.
Thanks, Geralyn. When you're talking about this with patients, do you use the term time limited trial? Do you use some other term, or do you just not name it at all and you just explain kind of the whole process without a name?
I think that but I think that there's a lot of variability in that. And I think that even brings up like Dr. Schnapp's point that sometimes clinicians are thinking about like an approach as a time limited trial, but it's not explicitly said. The one question that sometimes comes up is like, do they feel like this trial is like them being tested? And so some language might be like more nuanced, and maybe again that's kind of like understanding where the patient or their family is in terms of like, I think you can kind of gauge that in conversation if it's something that they would receive well, or if you just talk about it like this is like the ICU care plan, that was kind of the title of the piece of paper, and conceptualize it like that, just so again it might cause less stress for families.
More questions?
Thank you, Geralyn, for such a meaningful talk. Kind of building off Michael's question, I was wondering if you guys have thought through like, would it be helpful, like, you know, how we have like update DNR, DNI, like when someone's on a time limited trial, would it be helpful for there to be like an epic update, or because these are so transient, would that not be helpful, or if anything like that's come up in terms of like documentation?
Yeah, I know when we talk about documentation, especially in like the focus groups and interviews, we've talked about how it might be helpful if we have that ICU care plan and then you're able to scan it into the patient's chart. And hopefully, because it has the dates on it, it helps people understand like where in what part of like the clinical course was this plan relevant. And so we have talked about like incorporating it in the chart, like in the media tab or something, but not necessarily like having it on the side where you like click on it, because again, to your point, it kind of evolves and changes more quickly than a code status, although again, it kind of depends. So
We are right at 9 o'clock. So thank Dr. Palmer again for a wonderful grand rounds.